ankylosing spondylitis doesn't happen in a single day. It also goes, like sir was telling, pre-diabetic, diabetic, advanced diabetic. So it also goes like non-radiographic. So initial part, most probably the X-ray is not positive, but the disease has started. Very few subset, the MRI may be also negative, but usually the MRI is positive. So this is what is non-radiographic axial SpA. Then gradually over the time it became radiographic axial SpA. And lately the spine are getting involved. So that is syndesmophyte and everything in the spine. Okay. So this is how they progress. So the first part is inflammation. So inflammation always starts at these corners. This is the spine. Then over the time, if you are not treating it, then anything will be inflamed that has to get repaired in the body. And like fibrosis in the wound, this get repaired by the fat replacement. So that is what is called the fat metaplasia. So where it happens, so fat metaplasia is not a benign thing. This is a precursor of fusion, because the next step is, you see the bone is coming down, the bone is going up, and they are getting fused, they are about to fuse. So these concepts are very, very important for treatment purpose of you and when to start treatment. So inflammation, fat replacement, then new bone formation. Okay. So these are the again phases of axial spondyloarthritis. And every year this has been 5 to 10% of people, they are progressed from non-radiographic to radiographic. Okay, and which are the worst factors, or which patients usually progress? Those who are having HLA-B tension positive and those who are having high CRP values. If some patients, the CRP will be always high. We are worried that these patients are they are not doing well with medicine, and they are the subset which may develop this fusion, or they develop syndesmophyte. Those patients normal CRP all the time, the HLA-B tension is negative. Males are also more likely to develop this fusion than females. So female non-radiographic axial spondyloarthritis is more common. Previously we used to tell that ankylosing spondylitis mainly happens in men. But nowadays we are realizing, if you will take axial spondyloarthritis, they are 50-50. It is not a male predominant disease nowadays. When we used to depend on X-rays, those days it was a male predominant disease, because males are more progressed to radiographic sacroiliitis. But now axial spondyloarthritis, it is almost 50-50. So females are at equal risk of developing spondyloarthritis than male. So it's the same thing. So this is a very, very important diagram actually to understand how these patients. This is from I think 2021, not 11. So inflammatory back pain, if 100 patients will develop inflammatory back pain, will all patients develop axial spondyloarthritis or this ankylosing spondylitis to the last? The natural flow is 70-80% will develop non-radiographic axial SpA, they will fulfill their criteria. And very few fortunate people are there who will have a spontaneous remission. The cause is not known, you cannot predict which patients will go to develop. But most probably these patients are claimed, we have done this Ayurveda something and we got cured. But there are a subset of patients who never develop, who will never go to this downstream path, and they will get spontaneous remission. A subset of them will lie down with a very low disease activity state for a long time. Quiescent disease, very low grade disease. Many of them will flow like having a continuous on and off disease. And many will never develop ankylosing spondylitis or radiographic SpA. X-ray will never become positive, they will be always non-radiographic. And a very, very small segment, they will have very severe ankylosing spondylitis, like they will have everything fused, those pictures I was showing. So the natural time course is different among spondyloarthritis patients. You have to choose your treatment, aggression of treatment, depending the clinical feature. So all patients cannot be treated with the same bracket.